With all the focus on coronavirus, COVID-19 recently, it's reasonable for our staff and clinical employees to be concerned. It's important to understand that this is droplet transmission. So these are large droplets between 10 and 50 microns. They generally go about 3 feet and a maximum of about 6 feet. So the initial recommendations from the CDC were for an N95 mask and an airborne isolation room. That, I think, was an over precaution. You don't really need that. So they have changed to basically a medical mask and a general room with the door closed is adequate. The key is you do not want a suspected patient sitting in your waiting room. And I think it's very good that we have teams meeting patients at the doors of Hofheimer Hall and our other clinics. So they do a questionnaire and then mask them immediately before they come in. That's called source control, and that's really the single most important thing that we can do. As far as a medical mask versus an N95, there's a very large study published in the fall that went on for 4 years. And what they did was randomized groups in an outpatient setting during the influenza season to either a medical mask or an N95. And it turned out that there was essentially no difference between a medical mask and an N95 in protecting the healthcare workers from culture-positive influenza. So I think that the medical masks are going to be good for general purpose. The other issue is we don't want to waste PPE. We really want to conserve PPE so the people that really need it, those people screening at the front door, providers that are actually taking a history and examining a person who is high risk. We certainly don't need to wear them in staff positions where you're not clinical. It's not in the hallways. In fact, they've actually done studies in patients' rooms in the hospital, and all the air samples are negative. This really is droplet that falls to the ground within 3 to 6 feet. For a routine visit to the office, I think, one, we ought to be gearing up our telemedicine. We ought to be putting out the message that if a patient has respiratory symptoms, they should call first, and they should mask at the entryway. If they're not really sick, then they should probably stay home. We should be looking at canceling routine visits that for an annual physical or a well-controlled problem, and then rescheduling our patients when this is not as significant an issue. You could wear your PPE basically if you were going from room to room, as long as they're cohorted, in other words, they're all high-risk people under investigation, then you could keep it on sequentially. So you could keep that mask on, your gown, and your face shield if you have one. In between patients, I would take the gloves off and do good hand hygiene and put on a fresh pair of gloves. We are talking about both extended use of N95s and reuse of N95s. So extended use of the N95, basically you would wear that N95 through 5 changes before you needed to get another one. So say you wore it for an entire shift, then that would be one use. Have a Tupperware container and then put that mask face down in the container, and then the next shift you could do 4 more. If you were going to take it off between patients, then it's only going to be 5 uses within those 5 patients. If you're trying to do a full shift and you have to take it off to eat lunch, that's one of your 5 uses. But we are looking at both extended use and then reuse. Just make sure that if you're reusing, that mask is clearly marked with your name, and if you're concerned about the 5 uses and keeping up with it, you could put a little mark with a magic marker on the band so you know where you are in your allowed 5 uses. So it's respiratory number 1, fever second, and then it's an exposure history. Have they been traveled to an area where there is significant transmission? That would include basically every country in Europe. It would include South Korea, it would include Iran, and of course it would include China. Within the United States, the high-risk areas are the area of Seattle and its surrounding suburbs, and Westchester County in New York, and New York City has now seen a significant increase in cases. Yeah, so when you look at the efficacy of PPE, there's a study in China that looked at 44 very ill patients. One of them died, still on ventilators when the study finished, so sick people in the hospital. And with appropriate PPE, none of the healthcare workers caring for those 44 patients became infected. Not only that, there was no secondary transmission in the hospital to other patients. So it looks like appropriately worn PPE can be very highly effective. And also, when they looked at PPE in the hospital room, which is going to be much more than we're going to have in our office, and they actually looked at the PPE, none of the samples taken from the PPE was positive. There was a single positive from a shoe in that study, but that the person was not wearing shoe covers, and I don't think those are necessary, and I don't think one sample from a shoe is going to be concerned for transmission. I think first of all, if you're sick, don't come to work. That's the most important thing. We don't want sick people at work. Secondly, I would not be wearing PPE in staff offices. I wouldn't wear it in hallways. We really need to wear it only when we are actively involved in patient care, and in particular with patients who have a risk. And I think if we work together on this, we get consistent, credible information, I think we can really work well as a team, because this is definitely going to be an all hands on deck situation.